right? A lot of people are being evasive on topics of discussion that we're about to have. And let's just say it, diversity, equity, and inclusion. So we're talking about inclusion. We're talking about nurses shifting change. It's really time for us to stand up and have a voice and say something. Note to anyone who's watching, when you say, and you're right, when someone has a problem with DEI, it really shows who you are. It really does, because you can't tell me all of these years diversity, equity, inclusion has been around, and now all of a sudden you agree with an administration who is clearly, it's clear.
Welcome to Nurses with Voices. I'm Dr. Lendra, your host and fellow nurse who's traded in burnout for breakthroughs. I'm here to show you how to transform your nursing career into one filled with purpose, reduced stress, and incredible opportunities. Whether you're looking to start your own business, build generational wealth, or simply find a healthier role in nursing, this podcast is for you. Join me to explore practical strategies to overcome burnout, combat bias, and chart new paths in nursing. It's time to reclaim your voice and reimagine your future in healthcare. Let's get started.
Welcome back to another episode of Nurses with Voices. I'm Dr. Lendra, and today I have Dr. Roberto Roman. Dr. Roman is the Chief Innovation Officer for Vital Bridge Health, and I'm so excited to have you here today. I'm really excited to get into our conversation because we're going to talk about like some nitty gritties. The conversation is really, it needs to be had, right? A lot of people are being evasive on topics of discussion that we're about to have. And let's just say it, diversity, equity, and inclusion. So we're talking about inclusion. We're talking about nurses shifting change. It's really time for us to stand up and have a voice and say something with everything going on around us. And I want to hear your thoughts. I'm so happy to have you here. I'm glad you came on. So let's get into it. Tell us a little bit about you and go for it.
Absolutely. So thank you so much for having me on here. I know, mom raised us that you don't talk about three things: politics, religion, and money. But we're in a period that we have to talk about all of it, right? And, just a little bit of background about me. I am a registered nurse. I have been in healthcare for over 20 years. Started as an associate degree nurse and then worked my way through getting double doctorate, so a PhD in nursing from University of Miami and the DNP from Johns Hopkins University. Never thought I would do that. Never thought I would go that far. I was not one to think that would make my life career work, like as a student in academics and then getting into academics myself. And then just serving multiple roles throughout my career, which has been very rewarding. But everything has led me up to this point where, living my life as a closeted gay man, living in the Bible Belt of the U.S., growing up in a military family, living in military bases, through the era of don't ask, don't tell, I didn't feel safe or comfortable disclosing the authentic me because there was so much rhetoric and verbiage around how bad it is to be gay. And, as a child, that's extremely impactful. So it wasn't until just a few years ago that I felt compelled and just ready to live my authentic life. And the University of Miami, once I got into my PhD, it really gave me that opportunity to kind of reset myself personally and professionally and focus and support a community that is marginalized. And my research focus in LGBT inclusive healthcare. So serving as a registered nurse, getting a doctorate, and then being able to authentically step into spaces to be a voice for a community that struggles to fully represent themselves in an area that we still deal with so much health disparities within the LGBT community. And not only just the LGBT, once you start putting in other components, the intersectionality of being a minority, low economic status, we're just worsening disparities within the LGBT community. And now the politics of everything is making things worse within the community.
You said so much, and everything is just so rich. We need to unpack just what you said so far. So, and the double doctorates, right? The being a closeted man, right? And then you don't talk about politics. What is it? You don't talk about religion. You don't talk about policy. You don't talk about these things. And you're right. So let's start there, because now we can't keep quiet. Like, this is not the time to be quiet, because when you're quiet, people feel like you're not doing anything. This is why we came together as Nurseship Change, because we felt like the nursing culture wasn't doing anything. But now we see there are movements being made. There are, shifts being made, but we need more than the shift, right? We need more than statements. We need more. We need action. And that's what people are looking for. So we have to talk about the politics of it, because the politics is what's affecting us. And you mentioned how the LGBTQ community is being affected from a lot of the policies, from governmental politics. Share how.
So,
How was that being affected?
So I'm going to back it up just to when I started my PhD program. I was looking to see what I could do. So in healthcare, I knew that one of the hospitals was going for human rights campaign, the Human Equality Index, for being a leader in LGBT healthcare. And one of the components of it is research. And I realized within the department I worked at as a nurse scientist at the healthcare system, there was no research specific to LGBT. And the research studies that were going on did not collect social orientation or gender identity. So this was a huge gap of information that we're missing. And so that's what prompted me to start the PhD program. And when I went back to school for I wanted to do something in LGBT inclusive healthcare. So this was, we're talking about 2020, pre-COVID. This was before the pandemic hit. And so I just said, okay, this is what I want to do. Pandemic hit, started at the University of Miami, and already knew what the topic was that I wanted to do. And the University of Miami has a very strong focus within the LGBT community as well. So it was a great match. Fast forward just a year, each year into the program, as I was refreshing my literature search, looking at different data, I saw how Florida was progressively getting worse in regards to LGBT rights. And it started, one of the things was the Don't Say Gay law, also known as the Parental Rights in Education. And this was under the preface that, parents have a right to know what's going on with their children. So when you read it, the law is pro-parent, but then when you break down what it does, it essentially almost requires teachers to out students that come to them looking for guidance. And it's written in such a way that the teacher needs to identify if it's safe to disclose to the parents about the child either questioning their sexual orientation or gender identity, but there wasn't any education going on or training for teachers to know if it's safe to talk to the parents about letting them know about their child questioning their sexual orientation or gender identity, or just out of curiosity. So it kind of snowballed, and this is when we started seeing censorship of books that discussed LGBT topics. I think one of the big books was Two Male Penguins That Raised a Baby Penguin. That book was censored and removed from libraries, and sex ed was also censored throughout multiple grade levels. So in my PhD program at the very beginning, I saw this starting to unravel. And by the end of the PhD program, when I was looking at the LGBT, there's a movement map that you can look at to see how civil rights are, what the laws are supporting or going against the LGBT community. And unfortunately, like the map, it was like a heat map. Over the months I was looking at that map, you could see Florida getting redder and redder, more in the negative regarding LGBT rights. So by the time I finished the PhD program, defended my study, I realized just how important it was to start this 3 years prior. And I remember when I was awarded the LGBT or the Researcher of the Year by the LGBT Student Center, just thankful that I went to a private university that was able to support this topic when other universities, public institutions in Florida were being censored and either told you can't do this type of research. And then fast forward to today, the research lab that I worked at as a research assistant lost their grant funding. And their grant funding specifically was for LGBT community. And I have colleagues, students that are losing their F-31 grants and that are specifically in LGBT research. And just it's to the point where the stigmatization, the discrimination towards the LGBT community is just out there rampant and open. And it's a small percentage of the US population. We're talking right now about 9, almost 10% of the population identifies as LGBT. And it's such a hot topic. It's such a buzzword. It's a campaign trail. Like, this is what people are putting their campaigns on and targeting for something that is a small percentage in the grand scheme of things.
Does Doge have anything to do with the cut in grant funding? Or has that been happening before Doge even?
So this is definitely happening this administration. So when they're looking at the NIH, which is a huge funder of science, just healthcare science, they started looking at things that had specific buzzwords that were using, either things that we would look at as social justice. Research would just get cut, and not even a transition period, not even a warning, just saying that your study no longer supports the direction that we're going in. So I've seen colleagues on LinkedIn post the letters that they've received from the NIH, and it's painful. It's painful verbiage to read. And when you see that happen on a national, international level, because it's impacting studies all over the world that are NIH funded, because there's a lot of partnerships between universities here in the US with other healthcare systems throughout the world. When you see that type of verbiage, essentially you can read it as the government is saying you don't matter. And when we look at the websites that have been pulled off the internet from the CDC, verbiage, education points, talking points for providers and patients alike that talk about HIV, that talk about STI prevention, you're putting the community in a public health crisis.
Apps, you are completely on point. And this is why what we're doing with Nurse Shifts Change is so important. We have the rally coming up on May 24th, but it's more than a rally, right? It's more than about attending the rally. Yes, definitely come out, come to your capitals. Look at Hands Off. Right. Look how they came out in like the masses. There was thousands of people who came out all across the nation in support of a cause, right? Hands off of my Social Security, hands off of my government job. And listen, some of those health and human services jobs are right along in there. So I say this to say it's painful to watch what's happening to this country. And this is why we're going to have a movement, a Nurse Shift Change movement. It's more than a rally. This is something that's going to be ongoing because we need ongoing education, we need ongoing support, and we need to continue to make a stand. Because what's the saying? If you don't stand for something, you'll fall for anything. And right now, just sitting back and being quiet is just not an option. And it's not about being, we can't be aggressive, or we can't approach it. We don't want to. We have to do something, right? Like we have to. So what is your community doing right now to really push back on a lot of these changes, the loss of the grants? What is the LGBTQ community doing to fight back?
So pretty much, it's the pride parades are still happening, and the pride parade isn't just about, going out there in rainbow flags and rainbow gear. Pride started from a riot. Look at the Stonewall riot. This was a LGBT movement that was initiated by the trans community. They were tired of living in secrecy. They were tired of having to go to these speakeasy type bars or underground locations to live their authentic life. And it was this movement, the Stonewall riot, that really, said we're here and we're not going anywhere. So, we're in a period now where people feel like their rights are being stripped. They're worried about what will remain, and we're not going anywhere. You'll still see the community out in full force. In healthcare, you see the LGBT community. So GLMA, the Gay and Lesbian Medical Association, is doing a lot for the community. You have organizations such as Equity is one of them, Save LGBT in Florida. You have different organizations that are out there that are looking at what's happening. They're looking at policy, they're looking at politics, and they're standing up for the community. What I would love to see more of is, individual members, beyond the organizations, contact their representatives, let them know who they are, that their constituents and their votes matter. And that if they're voting against LGBT rights, guess what? Then I'm not going to vote for you.
Yeah.
I'll help campaign for someone else that does believe that my rights matter. And within the nursing community, and this is one reason why I stand behind Nurse Shift Change, nurses are supposed to be we are the most trusted profession. We need to be the most inclusive. And we need to stand up for the communities that don't have a voice. So while my passion, and my advocacy lives within the LGBT space, my push for rights impacts everyone, as we move through. So Nurse Shift Change and what we're doing here, standing for humanity, ethics, science, and social justice, is really getting nurses together and unifying our voice, because we're also one of the largest healthcare professions with over 5 million nurses strong. When you bring together those retired LPNs, allies, you look at all the opportunity we have, our voice is nowhere near as strong and powerful as it should be. And Nurse Shift Change is really trying to bring that together and break those silos of the different little specialties and different organizations and say, look, we're all together in this. Nursing has been about social justice since the onset of nursing, and we need to make sure that we're still advocating loudly for the communities we serve.
I can appreciate you mentioning the silos. I'm hosting an event in May, and a nurse reached out to me and she goes, is the event for LPNs as well? And absolutely, right? Like, I think, yeah, you're a nurse. And her response was, because, some people don't think LPNs are nurses. And this is part of the problem with when we mention silos, we want everyone to come out. We're all collectively, whether you're a doctor of nursing practice, whether you're a PhD nurse, whether you're a CNA, whether you're a registered nurse, LPN, listen, if you provide patient care, your voice matters, right? Your voice matters. And that's that march that you saw, that hands-off march. There were people of all walks, and I'm sure there weren't just people who got fired from the government job, right? They were people there in support of, and that's what we need to come together as not only as each discipline, right? Not just nurses. We're calling healthcare professionals, and this is how you shift change. This is how, if you stand for humanities, if you stand for ethics, if you stand for social justice, stand with us. Because this is how we're going to be able to make a change. And I'm so happy to be able to use this platform so that voices like yours can be heard, right? Each community matters. And to me, we're all together, right? So whether it's the LGBTQ community, you have your Latino communities. I spoke with Adrian Espinoza was on was on the podcast, and we have our Black community. We're all feeling the hit of DEI. We're all feeling, the needs of diversity, because we know what it's like to have that need for access, to be included or to be excluded, right? So when we talk about DEI, this is so that people can have access to environments where we don't normally have access, so that we can have seats at tables that we don't normally have seats. So when you look at the guise of how you mentioned of legislation being put in place so that it looks like we're helping moms, but we're not. The same thing with this whole DEI, right? When we talk about DEI, diversity, equity, and inclusion, DEI is being weaponized and it's
Hmm.
affecting all of us. And you're placing the guys like it's something wrong with DEI, forgetting why DEI was put into the place in the first place, right? Why it was put into
Yeah.
effect. There was so much underrepresentation. And to your point, there's an underrepresentation. There's only 10% of the LGBTQ community that's underrepresented. It's an underrepresented community that needs to have a seat at the table and needs to have access to the same seats that those who don't believe in DEI.
Yeah. And it's unfortunate, people are saying they don't like DEI, and challenge them. When I hear that, what part of DEI don't you like? What don't you like about
Right.
diversity, equity, and inclusion?
Right.
We're talking about bringing all people to the table. The weaponization is towards minority communities, but DEI itself has helped so many communities. When we talk about accessibility, we talk about, even, breastfeeding rooms in malls, in workplaces, all of this is coming together because there was a lens specifically put in place to look at other communities and their needs and what we can do to improve it. So, it's interesting when people say they don't like DEI, because you're showing me a shade of yourself that, you probably don't realize you're showing.
I'm so glad you said that. Note to anyone who's watching, when you say, and you're right, when someone has a problem with DEI, it really shows who you are. It really does, because you can't tell me all of these years diversity, equity, inclusion has been around, and now all of a sudden you agree with an administration who is clearly, it's clear, the writing's on the wall. Just the gloves are off, right? So there's no more trying to sugarcoat what's going on. The gloves are off, and it's so evident. We're very educated. Listen, we have double doctor degrees. We're very educated, so we see the writing on the wall. We see what you're doing, and it's unfortunate that we still live in a society where you want to believe the rhetoric, and I don't know if it's that you believe it or you want to believe it. My opinion is that you want to believe the rhetoric because it makes you feel good about the decisions that you're making and why you feel that DEI should go.
History is uncomfortable. History is uncomfortable. And, just even with the Smithsonian being told to look at what they're presenting, the history that is in their walls, and saying if it's appropriate or not, it's not for us to decide the history, what was appropriate or not. It happened. You
Mhm,
can't
mhm.
change it. You can hide it, and I don't know what the benefit of hiding any of that is, because we're going to end up reliving it. We need to know our history. We need to share our history so we can grow and learn from it. But it's crazy, every time I hear that, about DEI, and that it should be about merit. It's always been about merit. It was to give us the opportunity to have people with the experience and credentials to be able to have the opportunity to get jobs that they might have otherwise been overlooked.
Right, right, exactly, exactly. And you live in a state where there's been a lot of removal of education from the school books, right, and from the libraries. And
So depending on what you look at or what you hear on the news, some of it you'll hear that none of our books are being censored. Officially, maybe none of them have been censored, but I've
Mhm,
seen, and I know, friends that are teachers, I've seen the headlines here that, yeah, it might not be officially censored, but when you have teachers that are just more likely to remove their own personal libraries out of their classroom for fear of being reported, or fear of saying that they have, books that shouldn't be in their library, and just say, you know what, I'll just let, the librarians in the main library deal with that. Or when you have, you know, schools that are short staffed that might not have librarians, that are, supposed to go through all the books in the school to see if they meet what's appropriate. Yeah, it might not be an actual book burning, but when you're removing things and it's no longer accessible to students, Books that have been around for years that we grew up reading in middle school and high school, no longer accessible. Again, maybe not officially banned, but not available. That part's extremely telling. And when you see what's happening in academics and higher ed here, we're seeing censorship. I've had colleagues that, were called into the dean's office to find out why they're teaching a particular topic when they were hired for liberal studies to talk about those topics, because someone felt uncomfortable and, we're making it okay to report things that go against what the government says we should be doing. It's a scary time, and I know a lot of people, Florida hosts a lot of conferences. It's a beautiful state, great facilities to host it, but people are pulling away and don't want to come to Florida because they either don't feel safe, don't like what's happening. Florida's been home for over 20 years for me, and I'm not going anywhere. I'll be one of the last guys standing here fighting for what I believe is right, and we need voices here. So as long as I can stand on my own and be the voice, I will continue to do what I do. I've spoken at national conferences that said, they had pushback about hosting conferences in Florida. And, if we don't host it here and help the people that want to make a change, we can't leave them stranded. You can't just leave us to the wayside here in Florida. So we need to still have this connection with national organizations. There needs to be a conversation about what's going on and how we're doing it, because people, in essence, are boycotting Florida for conferences, nursing conferences, but there's information that needs to be shared. There's networking that needs to happen, and that happens in conferences. And also, I challenge people when people don't want to look at Florida, they need to look at Florida. Florida is the canary in the coal mine. We need to understand what's going on here, what's happening in politics here, because you do, especially in the South, you have a lot of copycat states. Legislation will be pushed in one state, people will see how it does to see what the talking points were against it, and they'll massage it and reinvent it in a different state. Might give it a different name, but the same premise. So, and I was just in California a few weeks ago, and I said to them, I was like, don't get comfortable. Do not get comfortable because you live in California and you're a liberal state that things cannot be undone. And I challenged them. I was like, look at Florida, look at Texas, look at different states around you, look at what's happening with your colleagues in nursing and healthcare, and don't get comfortable with where you're at because things can change quickly.
Absolutely. There was a nursing conference recently. I understand the conference, their posters had to be submitted beforehand because they couldn't have anything that was going to be about DEI, which tells me that there's things that we need to look at within our own community as well. And this is why we're asking for change, right? Because we need to have change and make movements in our own community so that we can remove those silos, right? To your point, when you talk about comfort, we're already uncomfortable because now I have to submit my poster to you on what the work that I've done to make sure that it doesn't have anything about inclusivity or equity.
Yeah. And we're seeing that everywhere. A podcast that I just recorded not too long ago, same thing. They said it needed to go for approval with their board. So this is where we're at. So these are all forms of censorship. If we're looking at, oh, does this make someone uncomfortable? Is it a buzzword that, we can't say? Are we going to lose funding because we've mentioned DEI?
Right.
When we talk about organizations, especially 501c3, so nonprofit, not-for-profit organizations, have to be nonpartisan. So people are afraid that if you use the wrong word, you're going to be viewed as political. And at that point, you can lose your tax breaks, you can lose your benefits of being a 501c3 organization. And I think that was kind of the hurdle that we saw very early on within this administration, was people were afraid about what they can do or say because of the backlash that can damage the organization. So there was a lot of probably legal counseling that was going on, trying to interpret what some executive orders might have looked like, what was being impacted, and what the organization is able to say within its parameters and not be targeted.
And this is why I'm so glad that Nurses with Voices we're who we are, right? And we don't have to rely on anyone. That's why we're not censored over here. We're not censored because we don't have to rely on anyone. We rely on us. This is a podcast that is for nurses, by nurses. And because we can't be censored, we can't allow anyone to tell us what to say, or especially when the message is so important, right? These are important messages, and hence Nurses with Voices. We have to have a voice, and our voices need to be heard. So I welcome you and others to come on the podcast. If there is something a message that you want to get out there, you will not be censored here on Nurses with Voices. So, and again, hence the nurse shift change movement. And this is how you shift change. It really is. You can't allow censorship. And I do appreciate you bringing up that point, though, because no one wants to risk their their 501c3s, and no one wants to risk that, or their other funding, right, in other areas. And I totally get it. But this is why it's important to have safe spaces like this, so that you are able to to voice your opinion and say, get your important message out there. What so as the Chief Innovation Officer, what is it that you do as the Chief Innovation Officer?
So when my husband and I started Vital Bridge about 2 years ago, it was his passion project to give back to the community. So he grew up, grew up poor. He was in, the Medicare, Medicaid healthcare system. He saw the challenges his family had receiving healthcare. So, we're both at a point in our careers where we're able to give back to the community. So he started Vital Bridge Health, and our mission, our silent mission, so it's not on the mission statement, but ultimately it's to disrupt healthcare. And our mission is to provide healthcare to the marginalized, underserved, uninsured community, regardless of who you are. We serve everyone, and do it in such a way that is affordable. So, as he's a PhD prepared nurse practitioner, specialized, certified in adult and acute care, so we both actually wanted to create concierge level care. So when you walk in, the practice has kind of a spa vibe to it. We have, I created planters and have like eucalyptus stalks in the lobby, so it doesn't feel like a sterile lab or hospital or a government office. And we set it up in a way that the hours are not 9 to 5 Monday through Friday. We can set appointments that will serve blue collar workers, people who can't take time off. So a lot of times when you look at what people say about healthcare is that, it's they're non-compliant. That's the word that we hear a lot in healthcare. Non-compliant. They're not paying attention. They don't want to do what they want to do. Well, it's not that they're non-compliant, but did anyone ask them, can they afford to take a couple hours off of work? They're deciding if they're going to pay rent or buy medications, if they're going to put food on their table, or pay for lab tests. So we need to look at the community and actually provide services that meets them where they're at. So we've had, home health visits with some of the patients that might not be able to come to the practice. We'll open up the practice on a weekend for a few hours to see patients, because if we don't see them in the primary care practice, guess where they're going to land? They're going to be in the ER. And then we wonder why our hospitals are overwhelmed and overburdened, and why people are coming in for things that look like should have been treated weeks ago. Our healthcare system is not set up to give fast, efficient care unless you have money. And even then, it's a challenge if you don't have the knowledge of how healthcare works. So we do a lot of in-house lab testing for those that need to have immediate results so they can leave with a care plan or a treatment plan. And we do things that most primary care practices don't do, because there's no benefit, or what they see is not a good return of investment for the business. So we flip in and look, okay, what is in the best interest for the patient, right? So when you can come in and you can get blood work done. You can have a sonogram done or an ultrasound done in office and know what's going on within an hour, or see if you need to go to the ER immediately versus waiting to go to a diagnostic center in a week, get tested, wait a couple more days, and then figure out, oh, you need to be in the ER now because you're even worse. So Vital Bridge Health really was developed to disrupt healthcare. And my role as an innovation officer, chief innovation officer, is to see what we can do to improve healthcare, essentially re-image it, because it's not, we have a ton of resources. The US has a lot of technology. We spend more money than just about any other, like country on healthcare, but our results, our outcomes are not any better than a lot of countries that spend less than we do. So one of the things that we did very early on, and I'll give an example here. So a patient diagnosed with diabetes. What is typical treatment? Put them on some oral medication, see if their A1C goes down. Wait about 3 months to see if the A1C goes down in 3 months. Tell them to check their blood sugar, stick their finger a couple times a day. But you don't feel bad with diabetes, right? You don't, it's such a slow transition of a decline in health that you don't realize that when your blood sugars are 300 and you've been living there for a while, you don't realize how bad you do feel until you finally get it under control. And when you're getting it under control, you feel worse because now your body doesn't know what to do when your blood sugars are normal. So what we did, any patient that was diagnosed with diabetes was either pre-diabetic or has uncontrolled diabetes. We would give them a continuous glucose monitor. Insurances will not approve that until you have been uncontrolled for a while, or you're on a high regimen of insulin, and they're like, okay, we'll give you a continuous glucose monitor and cover it. Well, we were able to have 2 different companies donate continuous glucose monitors, and we also found the coupons for the continuous glucose monitors. You're able to get like a 2-week supply for $70 discounted. Regular price is almost $200. So the patients that can afford the $70 would pay the $70 to get about 2 weeks worth of data. And you talk about changing adult patterns, adult behavior. Give them a continuous glucose monitor where they can see in live time how that, big Slurpee from 7-Eleven or the cornflakes that you thought were healthy for breakfast really spike your blood sugar. So when they eat, blood sugar spikes, they see it in real time, they know to adjust their eating habits. So some of the patients that paid, the $70 to have that 2-week supply will pay to stay on it even longer because they see the change that they can make. And, so when we look at healthcare, it's like, why aren't we using these tools sooner with everyone? We know the progression of prediabetes. You tell someone they're pre-diabetic, okay, eat better, exercise. Then they come back later and it's not any better. Okay, we're going to put you on, some sort of long-acting insulin and we'll see how you do. It progressively gets worse. So let's flip the script. Let's use our resources and let's actually see how we can improve healthcare from the beginning. Let's not be reactionary. Let's be proactive. So this is what we're doing at Vital Bridge to really just change up healthcare. And with the DMP and the PhD, my DMP helps me translate research to the bedside. The PhD helps me create new research. So I just use this skill set to really look at what we have going on, assess what's happening, because as nurses, that's what we do. We know how to assess. And then we need to go ahead and develop plans, implement, and reassess to see what's going on. So I've really, it's been a fun journey because I've really been able to dig into this and look at what's going on. And even look at disparities and see how systemic or implicit bias, I'll say, has impacted healthcare. So I consult with the providers, and one of them's like, I have this patient, African American, Black guy, blood sugar uncontrolled, and textbook tells you they're going to be on multiple medications, and still not getting controlled. There was nothing else to add to it. And, I was just talking with a colleague and she's doing research in TB, and, we're seeing the implicit bias. We're looking at how healthcare has essentially been designed by cisgender white men, scientists. And that's what is being taught in healthcare has been taught for a long time. So I just laughed. I was like, well, have you tried treating him like a white guy? He's like, what do you mean? I was like, if you had someone just newly diagnosed with hypertension, what would you do for a white male? He's like, oh, we would do this, this, and this. Let's try it. See what happens. Within a day, your blood pressure was under control. You know, and this was someone that his medications have just been increased over time. And it was to the point where, okay, we're hitting stroke levels here and we need to do something. And I was just like, flip it, go ahead and let's do this, because textbook tells you that a Black person is going to need multiple medications to get their blood pressure under control. And some of it, yes, a lot of people do need multiple medications, but when it's not working, let's look at what evidence shows us. And there's a lot of literature that shows us that even diagnostic devices for people of color don't work as well. So we then need to rethink how we're treating people and see how we can make healthcare better and remove these systemic biases that have just kind of permeated over the years through science and through practice to improve community health.
This has been such an enriching conversation. I really, really, really appreciate it. Thank you so much for coming on, sharing your expertise, your knowledge, dropping some gems, because that's exactly what it is. I mean, if you took away anything of what Dr. Roman has shared today, please, please, please listen to that last piece about the systemic bias and how it plays out into our community, how it just really it impact the impact it has, and ultimately why everything that's happening in the government, everything that's being taken away, the research, the grants, all of this, it all matters. So, and if you look at how pieces of the government is being taken away and how it's affecting, oh, well, this job is affecting this, and this job is affecting healthcare, and this job is affecting early childhood development programs. And that's how it works with healthcare. So everything that's happening has such a snowball effect. And you just gave a great example of why nurse shift change movement matters, why healthcare matters, and why we need to make a movement against what's happening right now in the government with the administration. So thank you so much for coming on today. How can people find you if they wanted to contact you?
So I am on LinkedIn. So Roberto Roman Laporte, or Roberto Roman Laporte. You'll find me on there, and just hit me up, slide into my DMs, and happy to talk with anyone that wants to have a conversation around these topics, or even finding out how we can move forward. Because the one thing we didn't get to talk about, I've been able to advance through my career through really good mentorship and having a circle of influence that really supports me, people that see things in me that I might not have seen in myself. So I'm always happy to pay it forward, help mentor people or guide people. And the question I get a lot, why, DMP versus PhD? I went for both. We can have that conversation, and then happy to guide you to like what would work best for you.
Absolutely. Be sure to make sure you guys check out the Nurse Shift Change movement. We have LinkedIn page, Facebook, Instagram. We are out here. So be sure to find us there. And until next time, make sure that you stay inspired, stay educated, and stay informed.